We will continue evaluation management, the topic that we started yesterday, today also. So we are talking about the levels of medical decision making and elements of medical decision making, and we reviewed the table, what we call MDM table. So this is the MDM table where you have details about each element, the problem, number and complexity of problems addressed, and the amount of data, the risk of complications. So we have levels on the first column, MDM levels, and corresponding elements. So what is straightforward MDM in relation to problem? The problem is self-limited or minor problem. And the data, if you look at data, minimal or none, then risk is very minimal. That's a straightforward case. Low complex, straightforward complexity of the case. That's what it is. So in fact, you have to go through this table and you have to get these elements by heart. You have to look at the problem. For example, let us look at the problem. The problems are different types, right? Acute problems, chronic problems, then injuries. That's what we learned in ICD. Acute problems, chronic problems, and injuries. So in low MDM, the problems are uncomplicated diseases. They're not complicated diseases. Whereas in moderate MDM, the diseases are complicated. That is a summary of this moderate problem. Whereas high, the problems, whether it is acute or chronic, they are life-threatening in nature. So that is a summary. Now coming to the data. So data you need to understand. Um, the physician gathers patient's data, right? Physician gathers the data, reviews the data. The primary source for patient's information is from where the provider or physician gets the information about the patient, from the patient himself, right? Patient himself or herself. Patient is the primary source for all the information, isn't it? So we are not talking about the primary source here. We are talking about the secondary sources from where physician gets the information. So basically, there are three categories of sources from where you get the information. Number one category, tests and documents. That means um, the investigations, lab investigation, radiological investigations, that is data, right? And at the same time, the old records, previous records, that is tests and documents. The physician has to spend time to review the old records, to review the results, order tests. So that is category one. Now category two, assessment requiring an independent historian. What do you mean by this? Who is an independent historian? Imagine a patient is Spanish speaking patient, and doctor doesn't know the Spanish language, he only speaks English, understands English. So what do you do then? There must be an a interpreter, right? Independent historian. So the physician has to spend time to deal with the independent historian. Now the patient's information coming from whom? Coming from the independent historian. So that is the category 2. Coming to the category 3, discussion of management or test interpretation. Or even before this, we have independent interpretation of tests. So anybody, you want to address this? What do you mean by independent interpretation of tests? Imagine a patient is with severe leg pain, leg injury. The patient is here with us in the clinic. So what do? You will order X-ray leg, right? X-ray leg is taken, but as you know, the radiology department will release the report only after next day, or maybe after 4 to 5 hours. Why the delay? Any idea? Because X-ray is taken, they don't release the report immediately. The X-ray film and report is released only after some time, maybe 4 5 hours or next day. What is the reason? Because the film has to be interpreted by the radiologist. The radiologist has to visit the center, he has to review the film, then he has to write the report, then only the film and the report will be released. So that is the reason for the delay, isn't it? But patient cannot wait. The treating doctor also cannot wait, isn't it? The patient is with severe leg pain, and the treating physician has to take a decision whether it is a fracture or not. So if you're a treating physician, what do? You will take the film. Without the help of radiologist, you will interpret the test, the film, is there a fracture or not. So for that, you have to spend time, right? That is independent interpretation of tests. I'll give you another example. Patient is with severe chest pain, 50 years. So what is the first test you will do when you have a patient with chest pain? You'll take an ECG, right? The first thing you do is ECG, electrocardiogram. Now again, the same thing with ECG. ECG is done, but the report has to be written by either MD internal medicine or cardiologist. It takes some time. But now, as a treating doctor, what do? You don't wait for the cardiologist or internal medicine. The treating doctor reads, interprets the ECG. So it takes some time, right? That is independent interpretation of tests. So the treating doctor gets credit for doing this job. Now the third category, discussion of management of test interpretation. So you have the patient here with chest pain, you have the X-ray, ECG. Now, if it is not your scope, what do? You will speak to a specialist, cardiologist, for example, right? You have to talk to the cardiologist about the test result, about the patient, and take a decision. And again, it takes time, right? That is discussion of management or test interpretation. So yesterday we have seen for every code 99202 there is a time that is determined, right? Average time. So as the data is increasing, as the workup is increasing, what happens? The time taken for the visit is also increased. So that is what we are talking about here. The complexity of data increases as the source of data is increasing. So as a coder, when you read the record, you have to understand what kind of data the physician is looking at. Is it only tests and documents, or old records, or any independent interpretation of tests is done? Is there any discussion? Accordingly, you will decide the data level. So we have the criteria. What is straightforward data? What is moderate data? What is high data? So you have to go through this table a couple of times. Then you're good to discuss further. Any questions about the problem or data? Let's make it interactive because
Sir,
yes,
on the left hand side, above moderate, level of MDM. So it's like based on two out of three elements of MDM. So are they talking about out of these three elements?
yes, because uh, for example, the category one, if it is moderate. Now in the moderate, we have three categories of data sources. category 1, category 2, category 3. In moderate MDM, must meet the requirements of at least one out of three categories. So either category 1 should meet, or category 2 should meet, or category 3 should meet. That has to be documented. Then it is considered as moderate MDM.
Sir, to say it a moderate level of MDM,
Hmm.
out of number of complexity data or the risk, out of these three, two should be at least known to select the moderate level of MDM.
Yeah, we'll talk about that. So let us focus on only one element every time. So we just discussed about the problem. Now we are talking about the data. So when you have these three together, what we have to do, we'll discuss.
Okay, sir.
Yeah. So yeah, because we're going to discuss about that actually. All right. So this is the data sources. You should be very clear about these data sources. From where, what all these sources, the data related to patient's health is coming to the physician. That's very important. The primary source is the patient. We're not worried about that. We're only concerned with the secondary sources. So these are three categories. Now coming to the third element, risk. Risk due to tests or treatment. It could be anything. Now coming to the straightforward, like I said, if it is just throat pain started last night, throat discomfort, so there won't be any treatment, there won't be any tests. So it's minimal risk or no risk. But if any test is done, for example, throat swab is done, is there any risk? Nothing, right? It is just swab
No.
test, no risk. But if a treatment has to be given, if it is a OTC like paracetamol, yes, there is a small amount of risk with the paracetamol. That is low risk. So you can just add one point under low risk, because these are only, all these are examples. Please understand, these are all examples. I'll give you an example. Low risk means, as far as the medication is concerned, OTC medication, over the counter medication. So the drugs are classified into different categories. OTC, the first one, over the counter medication. That means you don't need prescription to buy this medicine. It's in pharmacy. Sometimes they are available in any stores. That is OTC. Then prescription medication. The next level of category is prescription medicine. You need a doctor's prescription to get the medicine. Antibiotics. The next level of category is controlled medication. Controlled medication is like opiates, or certain painkillers, chemotherapy. So these are all controlled medication. Only a licensed physician has to prescribe. Not everybody can prescribe these medicines. That is controlled medication. So if it is OTC, you have the low risk. But coming to the moderate risk, we have examples here. Prescription drug management. If antibiotics are given, patient will have moderate risk of morbidity due to medication treatment. Now coming to the tests or procedures, minor surgeries or major surgeries. Any major surgery that has moderate risk. Now coming to the high risk, drug therapy requiring intensive monitoring for toxic. That means controlled medication. Chemotherapy, for example, if a patient is given chemotherapy, the patient has to be monitored continuously, because those medications have high risk, high risk of side effects or toxicity, whatever. And major surgeries. If a major surgery is planned, because doctor has to think a lot, right, to take a decision. So that is high risk. What you need to understand, these examples for each element under different levels, that you need to go through. They all most of them are self-explanatory. You need to um, memorize, remember, understand, and memorize. That's important.
Sir, for the
Yes,
data like moderate and high, what are the differences here?
yes. In moderate, out of these three categories, you need only one out of three,
At least one, right?
at least one. But in high, you need two categories. Two categories must be met.
Oh, yes.
That's the difference. So now we discuss what is straightforward MDM, what is moderate, what is low, what is high, and corresponding elements, including problem, data, and risk. Now let us come to. So it's kind of a checklist. It is kind of a checklist. Okay, we read the medical record. We understand. Now I'll give you the problem in a particular case. Maybe pharyngitis is a case. We have a patient with pharyngitis. The problem is one acute uncomplicated illness. Pharyngitis is acute condition, right? So it is meeting this one. This is low problem. Data, only throat swab is done. So data is again low. Risk, only OTC is given, paracetamol is given, nothing else. Because throat pain started only 1 day ago. Low risk. Low problem, low data, low risk. What is the final MDM? It is low, right?
Straightforward.
Low. Because all three are meeting. But here we have one rule called 2 of 3. Please make a note. 2 of 3 rule. 2 of 3 rule. So MDM table says you don't need all three to be on the same line. If you have any two of these three, that's enough to decide the MDM level. Now, with this rule, I'll give an example. A different patient, but with the same problem. Low problem because it's again pharyngitis acute. Only swab is done. That is low data. No medication is given. Doctor told no need for any medication. Take lukewarm water, gargling. That's it. Not even this OTC. So that means it is straightforward. Only gargling. It is minimal risk. Now, what is your final MDM level?
Low.
Again low. Why? Because you don't need three to be on the same line with the MDM level. Because you have two of three. Problem is met. Data is met. That's enough for you to decide your final MDM. That is low. So this is how you decide MDM. Once you have the MDM level, you have the E&M code. If it is a new patient, if it is a new patient, office visit, low MDM, what is your code? E&M code? Office visit, new patient, and low MDM. You just decided the particular case of acute pharyngitis, the MDM level is low. Now, what is your final E&M code? What are the codes? What is the code range for office visits? E&M code range for office visits. We have discussed on the very first day the codes for office visit. 99202 series, right? Office visits. You have, if it is a new patient, 99202, 203, 204, 205. The four codes. Now, if MDM is low. Which code you will assign for low MDM? Yeah, you can refer the book. It's an open book system.
203.
203. That is low MDM. Now your final the E&M level is 99203. That's how we'll assign. Because what you need is the POS, place of service, and you have visit type. Is it a new or established visit? And you have the MDM level low. Then you can easily assign the code 99203. So with the help of this table, that's how you'll get to know. As a coder, you have to decide what is the MDM level. Like I said, it is not the physician that is going to give you the level of MDM. So physician will only write the problem list, data list, and the treatment details. That's it. But using this table, you have to decide where the problem is falling, in which category, where the data is falling in which category. That's how we to decide. All right. So now questions. Any questions? So here you have to remember two of three rule. Yes, please.
Sir, would you please take one or two examples from case study so we can figure it out
Oh yes,
exactly?
sure.
Thank you.
We'll do that. So all right. We are in CPT from ICD. We have in ICD, right? Case studies.
Yes, sir. Case chapter 1 case study is also, it's
Yes.
like, I think it's on the same topic which we are talking about.
Yes. For example, we have this case. This is specialties infectious diseases ID. Now the patient is here in physician's office. Physician's office means office visit, right? Outpatient visit. Now, subject. We have to read the history to understand the patient's problem as well as what type of patient is visit is it new or established. 50-year-old male presents today with severe abdominal pain, nausea, and vomiting. So, is there any information whether patient is coming for the first time or previously was here? No information, right? So, take it as a new patient. Please make a note. The chapter 1 specialties ID case number 1, place of service is physician's office, and type of visit, patient type is new patient. Please make a note, new patient. If in these visits, in all these cases, if visit type is not mentioned, patient type is not mentioned, take it as new patient. Now, the moment you see physician's office, new patient type, you have to immediately remember 99202, 203, 204, 205. These four codes should come into picture, right? Now, the problem here is the patient has diarrhea, abdominal pain, nausea, and vomiting. The last 24 duration is 24 hours. There is diarrhea, abdominal cramping, and all these problems. So examination is done. Finally, food poisoning due to salmonella. This is the diagnosis. Now you know the problem. Food poisoning due to salmonella. And what kind of management is done here? Antiemetic. There's a drug that is ordered. Stress the importance of forcing fluids once the emptying has had time to work. The patient will call in the morning, if not better. So antiemetic was given, ordered, right? So there is a prescription medicine, basically. All right. Now, using this table, so it is definitely not straightforward, right? It is definitely not straightforward. It is not self-limited. It's a food poisoning. In case of food poisoning due to salmonella, there's infection, and the patient is receiving prescription medication. Then you're looking at the problem, acute problem. Is it acute uncomplicated illness, or if you go to moderate, acute illness with systemic symptoms or acute complicated illness? So your fingers are crossed whether it is moderate or low, but definitely it is not high. Why it is not high?
Not life threatening.
Not life threatening.
Yeah,
Very simple.
not.
Please remember, identifying straightforward and high is very easy, because high is life threatening, straightforward is very minimal. But the only problem is with differentiating the low and the moderate problem. That's where the actual confusion starts. There is always subjectivity. When I say subjectivity, in the sense, for example, three coders are working, two coders are working in the same case. Somebody says it is low problem, somebody says it is moderate problem. That is subjectivity. And the difference is very subtle. Sometimes both are right based on their argument. Some cases are very clear, you can clearly say that this is moderate, this is low, but there is always subjectivity. That is negotiable. If somebody says it is low problem, okay. Somebody says moderate, that's okay, it is negotiable. But what is not negotiable?
The high one.
The high one, or the straightforward one.
Straightforward.
And what is not negotiable one? If there's a new patient, if you are assigning it as established patient, that is not negotiable. So please remember, in the coding, always there are two things: non-negotiable ones, negotiable ones. Even the auditor, he has to look at these two things: is it a negotiable error or non-negotiable? So what I'm trying to say, yes. So you need to be flexible, but as long as you'll take some time to get expertise. But now for this case, it is acute illness with systemic symptoms, because the patient has multiple problems: abdominal pain, nausea, vomiting, and the patient is not able to take anything. Of course, is there any mention of dehydration? There is dryness around conjunctiva and mouth, slightly dehydrated. These are all systemic symptoms. So in this case, this moderate problem is moderate. Now coming to the data, apart from the patient, this data source, that is patient, any other data is ordered or any other data are reviewed as far as this summary is concerned. There are no tests, there is no documentation, no test are ordered, no test results reviewed, and no independent interpretation. There is no other historian, there is no discussion with another physician. So what is the data? None. Data is none in this case, isn't it? Coming to the risk. Risk due to, you have to look at two things: risk due to tests, risk due to procedures, risk due to medication. Three things, right? What are those? Risk due to tests, risk due to procedures, risk due to medication. There is no test done, there is no procedure, only thing is medication. Medication is prescription medication. What is the prescription? Prescription medication. So what is the risk level? Moderate.
Moderate.
Now put everything together. The problem is moderate, data is minimal, straightforward, risk is moderate. So what is the overall MDM now?
Moderate.
Moderate. So this is how you'll decide. So you have to fit the particular case into these elements. Where is the problem? Where is the data? Where is the risk? Now you know three things. Patient is its place of service is outpatient, office visit, and visit type is new patient. MDM is moderate. What is your final E&M level?
Moderate.
Yeah, level E&M code. E&M code. This is we decided it is moderate.
99204.
99204. That's it. So to decide the final E&M level, you must know these three things. Very important. One by one, you have to keep the checklist. You have to tick. Then finally, you will definitely, if you follow this step by step process, you'll come to this. If somebody
So,
assigns 99203, that's okay. 99203 is okay. Initially, don't worry about that. But if you assign 202 or 205, yeah, I mean, there's a problem. And if you assign 99214, that's a big problem. Yes, please. I think you have a question. What is it?
Yeah, sir, can you please come again one more time about the negotiable and non-negotiable?
Negotiable means non-negotiable. First thing is non-negotiable means totally wrong. Totally wrong. Because this patient is new patient, but if you assign 99214, because 99214 is also moderate MDM, and you assign into totally wrong because the category itself is totally wrong. That is non-negotiable. But if you are in the same category and you assign 99202, that's okay because in two instances, place of service and visit type, out of these three, yes, you're right. But the moderate MDM, that is slight error, that's okay. That's negotiable. There's a room for education. There is a room for education. That is negotiable. All right.
sir, in this case, like we chose the code on the basis of our MDM level, our whether the patient is new or old, and there is a third case, whatever. But then when we will go to the index and all.
No, in this case, there is no index. That's what we discussed right in the beginning. In CPT, it's not mandated to go to index.
So you can just go to right to the series
Yes, absolutely. That's what
on
this is.
the basis of the place of service
Yes,
and
because
whether the patient are new or old.
yeah, because you know the facts, you know the formula, you know the principles, you know the codes. You don't need to go to index.
So we don't need to exactly see, okay, what kind of drug we provided, or for the basis of drug we will go to this index. No, nothing like
No,
that.
no, no. Everything is depending upon the guidelines and this table.
Okay,
In
okay,
CPT. In
yeah,
CPT.
yeah, got it. Yeah, now we got it. Thank you.
Yeah. But if you want to still, for example, you're totally blank. I mean, uh, you want to go through the index. So what I have to do? I have to go to the index. Your main time is evaluation and management. So practically, it is not possible without knowing these, introduction, because you don't reach to the point to assign a code. But how to find the code from the index? Because index will give you everything. Your main term is evaluation and management. So this is evaluation management services. Now we have to look for office visits, right? This is office visit. It is new patient. It is will give the range 9920 to 205. And when you go there, your MDM is moderate. You'll assign 99204. That's how it is. But the
So,
practical purposes, yes, you can directly go to, because you remember you undergone this training, you know the principles, the guidelines, the codes as well. Yes, and you have the MDM table with you. You can directly go
yeah, so sir,
here.
like this case study, that question we discuss now.
Mm-hmm.
So earlier, what we learned, like the after the question and after the case study, the question was like assign ICDM code, right? But
Yes,
ICD-10 CM code. And now now we discuss, so how the question will come, like
yes,
assign
yes,
CP
yes.
code
Both
or
you would
assign.
assign both assign E&M code and DX code also, because like I said, you would assign two codes. The CPT code, E&M code is nothing but CPT code, right? CPT is 99202. Now diagnosis code, food poisoning due to salmonella. What was the code you got? A02 something, if you remember. That's the code you have to give.
Yeah, so it's supposed to be like this, like
Yes,
assign CPT and I
yes,
mean ICDM.
yes, absolutely. You have to give, because the CPT code, it will give the dollars. This diagnosis code will tell you why the patient is here, because you will not get dollars because of just because of this diagnosis code. Diagnosis code only tells you why the patient is here, but that the code that gives you dollars is this 99202 or 204, whatever. So this is a cyclical, repetitive, cyclical process. You have to continue to do the same thing with all the cases. And when you're working with these cases, if place of service is not given, assume it as office. If visit type is not given, assume it as new patient. Then you can. So the critical thing area is the MDM table. How to go through the MDM table using this summary. How to identify the problem, how to identify the data, how to identify the risk. That is what it is. All right. So now we discussed the MDM table. We know how to assign. What are the principles of assigning the MDM, as well as the final E&M code. Very good. Now let us look at the other place of services. Now it is time. It is your time. If I give you the place of service, you should be able to identify the code range. Yesterday we discussed emergency department, right? Did we discuss emergency department codes? If the patient is in emergency department,
No,
what?
we didn't.
Yeah, if the patient is in emergency department, now I'll give you a different place of service. ER, emergency room, or they call it as ED also, emergency department. What is the what are the codes you'll assign for emergency department? All that you have to do is flip the pages, or use the table of content, or use the index, and you have only 2 minutes
It's
within.
23, sir.
Sorry,
23.
that is place of service code. Yes, you're right. But the E&M codes, POS is 23. Good, very good. But the E&M
Nine
codes,
99281 to 99288.
perfect. So the code range is 99281 to 99285. So here there is no difference between new or established patient. The codes are same. Whether it is somebody is new or somebody is established, we have only one category of codes, 281 to 285. Very good. So if it is a nursing home, for example, the patient is in admitted in nursing home,
nine
it,
nine three zero four to 99316.
right? That's all. If you know the place of service, you should be able to identify the E&M codes immediately. And to give you quick reference, in the CPT you have these tables also. In the very beginning, they have given these tables. You can make use of these tables also. These tables, for example, office, if it is a new or established, they are given these codes. Then if it is a hospital visits, you have then you have emergency department, the codes are here. If it is nursing, then like you told, mine in 304, 305, 3606, these codes. So you can use these tables also. So go through these codes initially. They are self-explanatory, most of them. Once you have the comfort, once you're in comfort zone with this E&M, the codes, yes, that's where starts the application.
Sir, so
Yes.
with the nursing facility here, there are three bifurcation for that. One is initial nursing facility care, subsequent nursing facility, and the discharge services. All the codes are distributed among these three.
Mhm.
So difference for the third, I got an idea like discharge services, but first and second one, what's the difference? Initial and subsequent nursing facility care.
Right. So this is we discussed in the very first day. In case of outpatient, you consider whether it is new or established. All right. But in case of inpatient area, in case of outpatient, you consider new or established, right? But in case of inpatient, like in a nursing home where the patients are admitted, um, you will consider whether it is the initial visit or subsequent visit. Visit by the physician, because patient is on the bed. Now the physician has to go to bedside. If it is physician's first visit, that is initial nursing facility care. Initial nursing facility care. This first day. Now again, second day, third day also, physician has to go to the bedside, right? That is subsequent nursing facility care.
Yeah, okay.
If the patient is admitted, you consider initial, subsequent care.
So, what is prolonged services?
Yes, we'll discuss, because see, what I'm trying to say, it's a vast subject. It's a vast subject. So I'm giving you a couple of things which are very highly important to understand subject. So for now, please focus on these things and be comfortable with these things. Memorizing is important here. Usually, according they say don't memorize, because the open book system, every time you have to look into the book, you have to tell the answer, because memory leads to sometimes errors, right? Isn't it? We think that we are right, but if you code by memory, there is every chance that you may go wrong. But I advise you have to memorize certain things. Otherwise, you'll end up spending a lot of time in the open book. So these important things, go through this multiple times, understand these concepts. That's when you'll be more comfortable to go to other topics, because as a 50 pages, there are 50 pages in the E&M. So yeah, I mean we have time. We can discuss those things, or by the time you spend, for example, 10 days on this E&M with its basics, on the 11th day you'll be able to understand other things like prolonged services without anybody's assistance, believe me. Okay. All right. So now we reviewed the office visits, emergency department, and of course, you are able to identify codes for nursing home, and I'm sure if I give you another place of service, you'll definitely identify. Now let us jump into another topic within the E&M, that is critical care services. I think you heard about. I'm sure you heard about critical care services. Um, what do you mean by? What's your idea of critical care? When critical care services will be provided to the patient,
Where the risk is getting so high.
right? So if the patient is in life-threatening situation, that's when critical care service will be provided. What do you mean by life-threatening situation? When do you say that patient is in life-threatening situation? Suddenly, patient collapses, right? Collapses, and the first thing you do is check his pulse, check his or her pulse. Pulse is not palpable, and you look for the respiration stopped. That's a kind of critical condition we're talking about. So if that continued for another 3 minutes, patient dies. So that golden period, 2 minutes, that's very important. The entire staff, including doctor, staff, they have to rush and they have to provide critical care services. And there is CPR, right? What is CPR? CPR, cardiopulmonary resuscitation, CPR. So CPR is a basic thing that every professional should learn how to give CPR. They give sometimes, if there is no instruments available, they give mouth to mouth respiration, they give chest compression, that is the CPR, isn't it? So immediately, doctor rushes, they start IV line, they push adrenaline, all those life-saving medication, they start artificial respiration, chest compression, that is critical care services. These services can be given in any setup, right? Any place of service, wherever this patient. If the patient is at home, suddenly collapses, family members ring, 911, whatever, the local emergency number, immediately ambulance arrives. They start giving critical care services. Or imagine the patient is waiting in the hospital, clinic. Now he wants to visit orthopedic physician. He's waiting in the office, in the line for his number, suddenly collapses in the waiting area. So they will shout code blue, right? Then immediately the staff arrives, they start providing critical care services. Same thing happen, in patient area. So what I'm trying to say, critical care services will be provided in every service. There is no particular place of service. But as long as critical care services are provided, you will bill with only two codes, 99291 and 99292. Those are the two codes. Can you please visit these two codes in your book, CPT 99291 and 292? So this is critical care services. After your emergency codes, critical care services. We have, for every heading, we have the guidelines. Those are very important because whatever we're discussing, that are coming from these guidelines. Very important. We have to go through these guidelines. Then coming to the codes, we have only two codes, 99291. What is 99291? Anybody? Can you please read?
Yeah, they frame the time limits like if it comes for only 30 to 74 minutes.
Yes. Patient is in
Yes.
life-threatening situation. The physician provided critical care services, and the time duration is very important. Here, there is no mention of place of service or new patient established. There is no MDM also. High dollar codes. 9 into 1 is $500 straight away. 30 to 74 minutes. What matters is only time duration. But if it is 29 minutes, for example, critical care service are given for 29 minutes, you cannot give this code. You cannot. Minimum 30 minutes. Up to 74. But if it is beyond 74 minutes, then 9 into 2, each additional 30 minutes. These critical care services can be given for maybe 60 minutes or 120 minutes or even 5 hours also. We have a table here. Using this table, if you know the duration, these are the codes you have to assign. For example, critical care service are given for 2 hours, 120 minutes. How do you code? What are your codes? 120 minutes.
9929 into multiply 1 and 99292 multiply 2.
That's how it is.
Like that?
Because, yes, 99291 units 1, 1 unit, 99292, 2 units.
Oh, this cross is things like unit.
Yes. Times 1, there's times 2 in the meaning units.
Mm-hmm.
That means 99291, for example, $500. Then this is 99292, it is $300. 300 into twice, times 2, 600. 500 plus 600, 1100. Total billing is $1,100. That's all.
But less than 30 minutes, sir? It's so like
Yes,
after.
yes, that's a question. That's a valid question. What happens? Imagine the patient is in emergency department. Suddenly, patient collapse. Critical care services were given. So, for how many minutes? 29 minutes. You cannot use this code, but what you can use is the highest level in the within the category 99285. The highest level, because patient is in emergency department, 99285 you can use. That is a rule, because it is given here. Less than 30 minutes, appropriate E&M code. If the patient is in office, new patient 99205, established patient 99215. That's what it is. Understood, right? So this is about critical care services. And one last topic we have in the E&M, that is consultations. Consultations. Generally, for example, in India, we use the consultation for every visit. We say we are taking consultation. But in US market, consultation has a different meaning. In the E&M, there is a different meaning. What is consultation basically? Consultation, for example, I'll use very simple example. I'm a general practitioner, for example. We have a general practitioner, the physician, general medicine. General medicine physician, he can look at any type of case, right? Now he has a patient with chest pain. He is managing the general practitioner is managing the patient for quite long period. Today the patient is coming with chest pain. The patient has hypertension. The treating physician suspects it could be related to heart problem. If it is a heart problem, uh, he needs some opinion. So what do you do? What the physician has to do?
Referral.
Yes, he has to send the patient to a specialist like a cardiologist with a request. So what is important is request. Requesting expert opinion. The primary physician is requesting expert opinion from cardiologist. How do you request? You have to write a letter. Dear cardiologist, I'm sending my patient so and so problem, and he has chest pain. I have taken EKG. There is a questionable abnormality. Please review and provide your expert advice. That is a request letter. Now the patient goes to the cardiologist. Cardiologist will read the request letter, examine the patient, provides his E&M service, right? That is render service. Render service. Now we are talking about cardiologist. Now the patient is in cardiologist clinic. Now the cardiologist doesn't want to keep the patient with himself forever because the primary physician wanted only expert opinion, right? Now the cardiologist has to return the patient, has to send the patient back to the primary physician. How he'll send the patient back to the primary physician? With a report. What is the report? The cardiologist has to write, dear PCP, means primary care physician. Thank you for sending your patient. I have examined your patient. I've done some testing also. So patient requires certain treatment. I have advised him appropriately. Thank you for sending the patient for my opinion. That is a report the cardiologist has to write and send the patient back to the PCP. So what does it mean? Basically, the patient is returning, right? Return to PCP. That means the cardiologist has done consultation. The cardiologist has done consultation. We have separate coursework consultation in the office.
So this
What?
consultation will work for both the settings, inpatient and outpatient both.
Yes, absolutely. Because in case of OP, your codes are 99241 series, 99241 to 245. In case of IP, the codes are 99251 99255. These codes are applicable for whom? The specialist who is providing consultation. What is consultation? You must have these four things. What you call 4 R's. There must be a request letter. It has to be filed in the medical record. The cardiologist has to render E&M service. What is E&M service? Is no taking history, exam, MDM. Then there must be report back to the PCP, and patient has to go back to the original PCP. That is called consultation. If we have all these fours, then only the cardiologist can use 99241 series based on the MDM level, because these codes are have higher dollar amount than the regular office visit codes. If any one is missing, the cardiologist cannot use these codes. So that is about consultations.
So can you please explain one more time the render service?
Render service means the E&M service. Service means you have to take the history, examination, provide treatment. That is service.
So the primary physician will do that.
Yes, because patient
Uh,
is yes.
Sir, can we take an example of like annual exam here in United States. So basically, what happens is you'll go to the primary doctor.
Mm-hmm.
They'll ask for this, profile, your blood profile, like thyroid and everything.
Mm-hmm.
And once they'll get the report from the department, you will be seen back to the primary doctor. So it will be like going back again. He's requesting the for blood testing. We go to the for to give the blood, and everything report will be generated, and then we'll go back to the same doctor again.
Right. So
Can we
here,
say that annual exam is also a part of consultation only?
no, because here only one physician is involved. The ordering physician is only the same physician. The ordering physician and reviewing physician, the same. The primary physician is ordering tests. The patient is going to the lab, coming back with the results, and coming back to the same the primary physician. There is no second physician involved in this.
Oh, okay. Okay. So even the services are provided by the lab. It will not be considered as a separate physician kind of.
No, no, labs are
Okay.
not physician services.
Okay. Got it.
Sir, but this 4 hour,
Mhm.
like the first one supposed to be render service, right? Then request.
No, no, no.
No?
Request from PCP.
How? Like without doing E&M, how
No,
he. Uh,
Yes, sir. I have the same doubt as well that because first, how we are requesting if we are not done with the examination.
yeah.
now PCP uh, patient. Hold on now. So if you see here the notation, what I've written, PCP is sending the patient to cardiologist, right? PCP is sending the patient to cardiologist. You're able to see the screen.
Yes, sir. Yes.
Yes, sir.
PCP will bill 99202 or 203, whatever. He will bill. He will not, do the service, uh, for free. What I'm trying to say, after examining the patient with chest pain, the diagnosed chest pain, PCP will bill 99203 or 204, whatever, for his service. Now, patient is going to the cardiologist. Cardiologist is providing consultation. Now, cardiologist will bill for the same patient 99244.
Uh, I'm sorry, but diagnosis of the chest pain is not called as a render service. That is the render service, right?
Yeah, or the render service will do by cardiologist.
See, here you need to understand for whom you are coding, which report you have in your hand. Is it the report written by PCP or is it the report written by cardiologist?
If it's asked about the consultation, then it will go for, I mean like
Now, now
cardiologist.
you have the you're coding for cardiologist. Your cardiologist cardiologist visit happened. Now, as a coder, you're reviewing cardiologist report, cardiologist visit. Now, don't worry about the PCP. PCP record is not with you now. When you read cardiologist report, the first thing what will you see? There is a letter written by PCP that came to the cardiologist. Without this request, the cardiologist, he will not know, right, from where the patient is coming, why he has to examine the patient. So you're totally looking at cardiologist visit. The date of service, maybe 2426. Now the patient is in the cardiologist clinic, cardiologist office. You're only coding for cardiologist, not for PCP. Now, that's the reason the first thing cardiologist will do, he will look at the letter, request letter written by PCP. Then he will provide the service, E&M service.
Yeah.
Yeah.
Yeah, that's fine. So
After
cardiologist.
completing E&M service, then he will write the report. Thank you for referring for sending this patient. Now patient will go back to the PCP. So this is the end of the cardiologist visit. Now you assign this 99241 or 245, whatever.
So
Then
the
let
next question,
yeah.
on this case, this is these these codes are only for the ECP to the whatever consultation we take it. Uh, just only for the primary physician, or if the situation changes and we go to the ER and there they refer something, the codes will be the same.
Yes,
Yeah.
PCP will bill his own codes. This 99204. If the patient is in emergency room, for example, the PCP will bill 99282, 283, 284, those codes.
Okay.
Now the patient goes to cardiologist. If you are billing for cardiologist, then only you are billing this 99241 series code for the cardiologist, not for PCP.
And as per my understanding, sir, so the billing depends on these 4 hours, right? The range of billing for the consultation,
Yes,
it
for
depends on
example,
the hours. Yeah.
imagine, yeah, I'll clarify your question. Imagine this patient is not going back to the PCP. Cardiologist thinks that patient has to stay under the observation of the cardiologist forever. Cardiologist says your PCP cannot manage your disease is very complex. So come for follow up with me only because you have a complex disease. So this is not consultation. The cardiologist has to use now 99205 series codes because it's not consultation. Patient is not going back to the PCP, so it is not consultation. So the cardiologist has to bill the office visit codes 99205 204.
Okay. So both are interconnected basically. We have to go on the scenario.
Yes, because 241 series, these codes are high dollar amount than these codes.
Mm.
Because to be able to build these codes, this is the criteria. If this criteria is not met, then you have to cardiologist has to use this 99205 204 series. If this criteria is met, then you have to use you can use this codes. All right. Yeah, I mean, please do not hesitate if you have any further questions. Let us clarify now itself.
So just one question. From the like we moved to the cardiologist visit, we came for the consultation, but now since we have more complications, so we become the permanent. So our first, which one we took it as a consultation, that will take it as a consultation, or now consultation has completely removed and this will become our initial primary visit course only.
Yes, because to be able to bill these consultation codes, which have the higher dollar amount, the patient has to go back to the PCP. If the cardiologist is not sending the patient back to the PCP, then the cardiologist has to bill these office visit codes. So the patient will continue to come to the cardiologist for follow-ups.
Okay. Yeah. Thank you.
Yeah.
So far I'm good, sir, but I need to read maybe tomorrow.
No problem. No problem.
I
Just
have something.
go through these. I think I'm sure you have taken some notes, running notes, or you can watch this record again and again. Just focus on whatever we're discussing as of now. Once you're comfortable with this, then you can browse any page in the ENM, other things. And tomorrow we'll continue to discuss ENM, the last day for ENM. Um, then we'll move to the next section, surgery. That's on Monday, but tomorrow again we have time to discuss.
Uh, Sir, I have one question. You are saying like outpatient and inpatient, the code start with 99241299245, but the books is showing starting from 99242.
Yeah, I mean that's okay because
That's okay.
yes, 99242. Okay, that's fine because 99241 was there, it was deleted. Now the course was starting with 99242.
But that is not meant 99241. 99239 after
Let
99242.
us let us look at those codes.
Just
99242,
go
right?
through the previous. It's
Yes.
like 40 page number.
Page number is 23
This
and
one.
24.
Yes, this is
Yes.
99242,
Hmm.
243. Previously it was there 241 was deleted. Now we have only four levels. Whether it
But
is
sir, go through the please go through the 40 page number. It shows here 99421 digital evolution, but something
40,
different. Yeah.
this is we are in 24, page number 24 now. I mean PDF page number.
No, no, no. Okay, sir. I was confused. Yeah. Fine.
So again, these codes, whether it's new or established, the same codes 99242, 243, 244, 245. But if it's inpatient, your code start with 99252, 253, 254, 255.
Okay. Yeah.
Yes.
Thank you, sir.
So read this introductory paragraphs. What is consultation? What is the definition of consultation? It is written here. And all right.